Hi, my name is Kirsten Thornhill. This is for HP 702 Applied Sports Science, being recorded on November 17th, 2020. The effects of resistance and aerobic training on flow-mediated dilation and endothelial function. Little introduction here. The use of this high-resolution ultrasound to assess endothelial function, EF, via this flow-mediated dilation technique was first investigated in 1992 by Sealer Major and colleagues. The assessment of brachial artery, FMD, has become an extremely popular measure in cardiovascular research due to the ease of use, cost effectiveness, and its non-invasive nature. And due to this pivotal role of endothelium in the maintenance of our vascular tone and reactivity, the importance of maintaining an intact and functional vascular endothelium is somewhat quote-unquote obvious, according to some of the literature. Exercise has been shown to improve numerous risk factors that may induce an indirect effect on EF, with studies showing support in young, healthy, and diseased populations. So in regards to EF and ED, before defining endothelial function, let's first define endothelial dysfunction. So endothelial dysfunction is reversible and a functional alteration of our endothelial cells. This results from an impairment of oxidative stress and nitric oxide availability. ED is evoked in patients with hypertension, as it promotes vascular progressive damage and atherosclerotic and thrombotic complications through continued oxidative stress on these arterial walls. Our endothelial function is a critical determinant of our vascular health and function. It plays a key role in the regulation of our vascular tone. These endothelial cells respond to blood flow-induced increases in vascular wall shear stress by increasing vasodilatory autocoid synthesis, leading to vascular smooth muscle relaxation. I've included a figure here from a 2016 study showing a very intricate but simple to see dynamic between our oxidative stress, inflammation, and decreases in nitric oxide, leading to ED, potential atherosclerosis, and hypertension. So the clinical assessments of endothelial function can be assessed through different outcome measures, three of the most popular being a cardiac catheterization, venous occlusion plus thermography, and of course our ultrasound FMD. Again, FMD is currently our gold standard for non-invasive assessments of conduit artery endothelial function because there's considerable clinical trial experience, validation, firm links to biology, and associations with cardiovascular events, according to Dean Field and colleagues. So FMD, in a general sense protocol, it's conducted by imaging the brachial artery with baseline readings, followed by an occlusion period through a cleft inflation, 3 to 5 minutes of this occlusion, and then a release. This test, again, represents the gold standard for clinical research on conduit artery endothelial biology, and this has really opened up a new field for vascular epidemiology. FMD can assess measures of nitric oxide biology, inflammatory cytokines, regulators of thrombosis, adhesion molecules, as well as endothelial damage and repair. Thus, this assessment can evaluate young patients, including children, permitting testing of lifestyle and pharmacological interventions on endothelial biology at early preclinical stages. This is the paramount because this is when disease progression is most likely to be reversible. So diving right into AT and FMD literature. So aerobic training has been shown to persistently improve vascular endothelial function as well as reducing both systolic and diastolic blood pressures. This has been shown in various populations, including older men, obese women, etc. So RT and FMD has been shown to increase mean brachial artery diameter and increase the post-occlusion blood flow. The most significant finding from some of the RT literature has been shown to enhance resistance vessel function. Thus, what is the support for AT and RT on FMD? So separately, they've been shown to provide beneficial effects on brachial artery FMD and, again, the resting peripheral blood pressure. AT and RT combined have shown to significantly increase FMD and endothelial-dependent vasodilation. An interesting study found that AT alone, RT alone, and a combination group enhanced endothelial function significantly, showing an even stronger positive relationship between how often these participants performed RT with improvements in EF. So as a quick debrief, brachial artery ultrasound FMD is a commonly used and again gold standard, widely accepted measure of peripheral microvascular endothelial function. However, there are a limited number of studies examining the effects of a combination of RT and AT on EF. Specific aerobic and resistance training could be necessary to reduce these primary and secondary cardiovascular events. And the pathogenesis surrounding EF and ED is likely multifaceted. Thus, three main gaps in research I'm seeing. What are the mechanisms responsible for these changes in EF? Again, multifactorial, multifaceted. Going back to that figure I provided, looking at inflammation, we're looking at nitric oxide levels. We're also looking at the effects of shear stress in the endothelial walls. 2, there's inconsistent and varying effects of different exercise intensities on endothelial dysfunction. What is the prescribed frequency? What is the duration? What regard do we prescribe a combination amount of RT and AT? Which leads us to number 3. What combination of RT and AT will meet the minimum requirement for improved EF? 1, this is population dependent. 2, this is frequency determinant. If I'm working with an elderly individual, the frequency of incorporating RT and AT into his exercise program may be at a slower pace versus working with an athlete that may already be performing RT and AT with frequency to continue over time. Thus, application. Clearly, I'm going for more of a clinical application approach. However, this can also be applied to athletic performance. So clinically, we're seeing improved functional capacity, quality of life in patients with coronary heart failure, CVD, patients at risk. We're seeing reductions in BP, reductions in the pathogenesis of this vascular disease. And in athletic populations, we're seeing improvements in cardiovascular function, increases in blood flow, increases in CRF. Thus, regardless if the athlete is in an endurance-based sport, we're seeing improvements in aerobic capacity.